to see family and reduce staff. So we have these seasonal trends, and the question was really for us, how are we dealing with seasonal variation and also the secular trends to discern what is due to COVID-19 and what is probably just variation over time. So the modeling framework, so we ask ourselves two main questions that we further stratified. The first is, to what extent have COVID-19 related lockdowns led to TB healthcare service disruptions in terms of the number of TB tests conducted, treatment initiations, and also unfavorable treatment outcomes? And also, as part of that, how have lockdowns affected expert positivity? So in other words, the positivity rate amongst all people tested with GeneXpert in the countries. And then the second sort of questions were, what is the epidemiological impact of these healthcare service disruptions on TB incidence and mortality? And related to that, what is also the potential of recovery measures? So the first we addressed with an ARIMA time series or forecasting model, and then we used the outputs of that model towards our second exercise, the transmission dynamic model. And we've seen from Nim Patti in the last session or so how you could very elegantly incorporate that into a single transmission dynamic model, these data. But for us, we chose these kind of two-step approach because, first of all, there was a big interest in understanding and developing estimates of healthcare service disruptions itself, which we felt it was important to distinguish uncertainty related to the data from the overall uncertainty of parameters. And secondly, we felt that it was also interesting to sort of use these outputs from the first model to inform the transmission dynamic model. So you'll see in a minute how we did that. First question, to what extent have COVID-19 related lockdowns led to TB healthcare service disruptions? So we used an autoregressive integrated moving average model, which is commonly used for to forecast time series data. The model predicts future values based on past values, looking at the overall trend, so including secular trends, but also takes account of seasonality and also random behavior of time series data. So these are all incorporated and dealt with this type of model. And then we implemented this model using the R function auto-ARIMA, which uses a variation of the Heinemann-Kandakar algorithm. So this is an established algorithm for this model. And then there is an additional test used to assess this forecast, whether it is consistent with the observed data. So model scenarios, we had a predicted or a forecasted trend. So this was an expected trend in healthcare service indicators in the absence of COVID-19 lockdowns based on pre-COVID-19 trends. So we had a hypothetical no COVID scenario in the country, and then we had the observed data, which were healthcare service indicators during the time of COVID-19. And so we used the pre-COVID period to predict, and then compared the predictions in the absence of COVID-19 hypothetically to the observed trends in healthcare service indicators during COVID-19. The data analysis, we looked at the percentage difference in the observed versus predicted TB indicator values. We had aggregate annual estimates. So we basically first looked at the time series, but then we also used aggregate data for 2020. This was based on April to December because this is the period of the pandemic, and then annual trends from 2021 onwards. And then we used, we developed best estimates and 95 uncertainty intervals as model prediction intervals to look at these aggregated annual estimates and describe uncertainty in the modeled outputs. So this is an example about how we worked. Here you see the number of expert tests performed in South Africa as an example from 2017 to 2022. You can see here the same trend, the observed data, which is the circles here. You see the seasonality happening, not much going on over time. So roughly from 2017 to 2020, maybe a slight decrease, but otherwise pretty stable. And then you see here the observations during the months of COVID-19 from March 2020. You see here the decrease in testing, and then you also see the ARIMA forecast, the predicted trend, so this, which allowed us then to compare the observations against the predictions. And we did this on the right-hand side, where we looked at the percentage difference between the observed or observed values and the predicted or expected trend to calculate percentage differences, which basically gives us some estimate about what the disruption of services has been, in this case of expert testing. So you can see this on this side where we present the percentage difference between observed and expected trends. So that's the model itself. I'm going to present the results now from this analysis. So this is data from Brazil on the left-hand side. You can see here the observations, then the prediction as well. And you see the observed data where you see that there's quite a reduction in the early times of the COVID-19 pandemic. You can see this here in the observed trend in terms of the number of expert tests performed. And you see then some partial recovery during 2021 and even an increase beyond 2022, which probably relates to catch up. So in other words, tests that were not done or people who did not seek care were then predominantly tested, but you see a clear disruption or a clear decrease in testing in the early phase of the pandemic. Similar observations we had for India. We were just not able to do the modeling here because we're still waiting for data from the earlier years, 2017, 2018, but you also see here quite a substantial reduction in the number of tests. Also note the different scale here. These are millions of tests performed and quite a substantial decrease here to see, but we're waiting for the additional data to actually quantify these disruptions. And then finally, South Africa, similar pattern, quite a substantial reduction from about 200,000 tests performed or expected in the early phase of the pandemic down obviously per month, and then down to about 100,000 in the early phase with a subsequent what we call recovery. At least you see how the observations match more clearly than the expected trends from the model in later years. Increase in percentage positive expert results. This is the percentage expert positive, which generally in Brazil and South Africa is around 10% of people with presumptive TB who test positive with expert. And you can see here that there is a slight tendency towards an increase, or this is significant. This is an increase up to 15% in the early phase of the pandemic, in the same pattern. Somehow for South Africa, not as strong, which we think might relate to people with more severe disease accessing care, where the index of suspicion or the pre-test probability for TB was probably higher in this phase. And then the reductions in TB treatment initiation. So this is case notifications, if you want. So, and you can see here also a substantial decline in the number initiating treatment every month. This is data for Brazil, where you also see the drop in case notifications in the month from the start of the pandemic, roughly March, April 2020, with later recovery in this model consistent with uncertainty and pretty close to expected trend later on. Here in India, you see quite a different picture here, because there are more substantial disruptions in terms of the number of people who initiated TB treatment, and you see that there is no recovery here. So the number of people initiating treatment has remained low in India, and this is quite worrying. One can argue how strong this model is, and maybe there are other things that come into play here, but it is quite worrying to see. You even see that the seasonal trends are persisting here in the observations, but quite a lower number initiating TB treatment compared to what you would expect if you look at the pre-COVID trend. And then finally, South Africa, the reductions in TB treatment initiations, similar to Brazil here with some partial recovery in the later stages. And we've also compared the number of people tested, and this is percentage differences between observed and expected or predicted. And we've just putting these on top of each other. So the number of tests performed versus the number of people initiating treatment. And you see that these are pretty close to each other. So in other words, the reason why people did not initiate testing probably relates to the reduction in, didn't initiate TB treatment, probably relates to the reduction in TB testing and probably accessing of services rather than, for example, initial loss to follow-up amongst people who receive testing. So this is pretty consistent with people either not accessing care during COVID-19 or accessing care, but not receiving proper care in terms of TB testing. So let's look at the outcome data. So these are unfavorable treatment outcomes. So we've looked at all reported outcomes in the time period, the common indicators, including not evaluated. And then we have unfavorable outcomes, failure, death, loss to follow-up. And we've looked at unfavorable outcomes, including not evaluated and excluding not evaluated, because it's not very clear and it's not also inconsistent in the countries how not evaluated or missing results are being dealt with. But you can see here in terms of the percentage overall unfavorable outcomes in Brazil, there is an increase observed towards 25% unfavorable outcomes in the early phase. This goes closer to our uncertainty intervals in the modeling, but this is consistent with disruptions that have also affected the potential for treatment success. Here, India, and in India, surprisingly, we did not see this. So we have evidence of disruptions and more unfavorable outcomes in the early phase of the pandemic, but then over the more recent time period, you see that this is very close with what we expected according to the time series forecasting model. So it's not clear why this is happening. So we see a lot less people starting TB treatment, but apparently, according to official data, the disruptions in terms of outcomes are not as pronounced compared to Brazil. In South Africa, the same pattern again as in Brazil. We see quite an increase in unfavorable outcomes over the whole time, with very little recovery in later. Well, this is only up until 2020, so we can't really say, but that was a limitation, that we only had treatment outcome data for South Africa up until the end of 2020. But you see here also a marked increase in the unfavorable outcomes consistent with potential health service disruptions in this time. We also looked further about different types of outcomes, and here the most important one is death during TB treatment. You also see some evidence here, at least in the early phase in Brazil, of an increase in TB death during TB treatment. We obviously don't know whether this relates to people being treated at a later stage, where they might be more likely to die early on, or whether this relates to poor monitoring of treatment in the course of treatment, but also some evidence here that at least slightly the deaths have increased during this time. The same we see in India, but as you see, again, only for the early phase of the pandemic. And then in South Africa, more pronounced here, a significant increase in deaths during treatment, up until 10%, which is quite high, I think, and sort of borderline increased in more recent times, or at least in the end phase of the year 2020, where there was the second wave of the pandemic happening in South Africa. So here also evidence for a substantial increase in people dying while being on TB treatment. So this is a very hectic table. I'm going to skip this in the interest of time. This is a bit easier to read, You see here again, like a comparison, the number of expert tests conducted, where we have limited data for India, but you see here, blue is the year 2020, April to December, green is 2021. And you see here that especially in the first year of the pandemic, in both Brazil and South Africa, a considerable decline in TB testing. South Africa, an estimated 30%, roughly, I can give you the exact numbers, but if you look at that, there's about 30% reductions in testing, about 25% reductions in Brazil, with less of reductions compared to expected values in the second year in 2021. Number initiating TB treatment, Brazil about, I would say 18, 19%, India much higher and consistently high in the second year of the pandemic, 2021, and then South Africa in the first year. And you see here, this is definitely more than what was reported to WHO in terms of the number of people initiating TB treatment, with the limitation that our data do not include drug-resistant TB treatment. So this is first-line treatment, but you see here about 30% reductions in treatment initiations, pretty similar to what we saw in testing, and a partial recovery, you could say, in 2021. Higher unfavorable outcomes, as discussed, particularly in South Africa, with especially percentage death during treatment being increased in Brazil and South Africa, where we had data, and surprisingly very minor only in India, and we're not sure about what this is about. We're still discussing this with the India colleagues. Very briefly here, the results from the think tank assignment. So this was a consultancy, an assignment that we took on, where we were asked to look into subnational data. So these are the 9 provinces of South Africa, and you can see here that there's substantial variation in how TB healthcare services were affected during the COVID-19 time. You see here for the year 2020 versus 2021 in green, you see here that disruptions or reductions in expert tests conducted compared to expected started from 40% reductions compared to expected. You have the national average, and then you have Mpumalanga here with about 20-30%. And you also see that Gauteng and Mpumalanga here show actually increases in testing, in the number tested compared to expected in the second year in 2021, which might relate to measures being put in place. But I think it's very clear from that pattern that there's a differential impact of TB healthcare services during the COVID-19 pandemic. Same pattern here for number initiated or initiating TB treatment, which you can see varies widely. The percentage cure or completed TB treatment here varied widely, so reductions of almost 10% in the Free State, up until a slight increase even during 2020 in so more or less no change in treatment success rates in Mpumalanga. So substantial differences also here, and also death during TB treatment, where you can see they're ranging from an increase of about 40% compared to expectations up until no difference in Limpopo here. So again, really interesting to see the differential effect with all the limitations that obviously come into place in terms of how well our model predicts the expected trends in the absence of COVID. But generally, we can say here that it is worthwhile for countries to look at the subnational level and look at data and look at countries or regions and provinces that are more or less affected, and try to really establish measures in areas of greater concern. This is a study that we, together with a think tank and colleagues also from the NICD in South Africa, submitted as an abstract, and this was accepted for an oral presentation, where we're going to give more details on these data later on. So disruptions in Brazil, India, and South Africa. What can we conclude from this first modeling exercise? We have substantial reductions in the number of expert tests performed in Brazil and in South Africa, with data lacking for India. possible reasons: less people accessing healthcare, reduced service provision. We've seen the sub-country analysis, and then an increase in test positivity, which might relate to preferential care seeking of people with more severe disease and higher index of suspicion in the COVID time. We have disruptions also in terms of the treatment initiations, as discussed. I don't think I need to go into detail here, but you've seen that COVID-19 also has led to an increase in unfavorable outcomes with greater uncertainty around what happened in India. This is the question 2, which we looked at the impact, the epidemiological impact of these healthcare service disruptions on TB incidence and mortality. We used a country-level transmission dynamic model of TB in South Africa, consisting of 11 compartments representing the natural history of TB, and then subdivisions for HIV infection progression and ART. This model, or kind of the prototype of this model, was developed as an in-country effort through the SECIMA DTTC TB modeling partnership with several people involved. And we've kind of taken this model and developed it further and used it for this effort as well as for other studies that we're currently running. And this was implemented in R as an ODE model. Just to show the model itself that we used, so this is very much in line with everybody of you will be familiar with. We have susceptible people, susceptible to infection, latently infected recent versus distant. We had subclinical and clinical TB included. We have compartments for awaiting diagnosis, where we are able to do more research for the care cascade in other studies. But here, just to say that we have a compartment for people who are deceased and who previously sought care, which is relevant also for calibration. And then we have treatment. We have people who recover either partially or they remain at high risk versus low risk. And then obviously we allow for relapse and reinfection. On the right-hand side, you see the subdivisions for HIV infection, progression, and also ART initiation in a relatively simple format, but important as this is focusing on South Africa. So we're starting here we're working only with South Africa. And we're planning additional modeling, for instance, for Brazil with the Brazil team. But this is now the data are referring to South Africa. How did we address COVID-related healthcare service disruptions? We sampled from the uncertainty intervals from the ARIMA data analysis or ARIMA modeling analysis, and we're using this in a kind of a Monte Carlo approach. We are able to reduce the transmission coefficient, assuming that there was less contact during the COVID-19 period due to lockdowns, the reduced access to diagnosis, care seeking. So this is where we use test data and treatment initiation data as a proxy for reduced access to diagnosis. We are able to increase the probability of incomplete treatment, which is not shown here actually. But this is basically people, oh yeah, it's shown here. So it's basically people remaining at high risk after leaving treatment with a higher risk of being sick again afterwards, or continuing with disease and progressing again. We do have additional structure for case finding in the event of subclinical disease that's mainly used for other studies. So this was not used here in this model. And then we're not showing here that we also vary the probability of death during TB treatment. So this is another factor not shown here that we could use the data for. The analysis strategy, as I mentioned, we used the data, the output from the ARIMA model to inform the analysis of the transmission dynamic model in a Monte Carlo type of approach to include the uncertainty around the ARIMA estimates. The model is calibrated to various calibration targets. We're using a Bayesian posterior estimation approach, sampling importance resampling. We have historical data from the pre-COVID period. So up here, you see the general population estimate. We have HIV prevalence estimates. We have ART coverage from UNAIDS. We have the WHO indicators for all TB incidents, HIV positive TB incidents. We have TB mortality. We have TB case notifications. We have TB prevalence from the most recent National TB Prevalence Survey. This is the overall estimate, one data point. And then we also use data on the proportion of prevalent people with prevalent TB who had subclinical TB, and also those who reported to have previously sought care, which is now a nice way for our compartment to actually calibrate the rates of people re-seeking care after that to observe data that we had from the prevalence survey. We used different model scenarios. So we had a no COVID-19 scenario, hypothetical. So this is assuming no disruptions. We had pandemic scenarios. Scenario one assumes disruptions occurred at the level of the outputs of the ARIMA model. And where we didn't have outcome data, we assumed that in 2021, at least 50% of disruptions occurred compared to 2020, since we're still not, we don't have the data for South Africa for 2021. We have a number of additional scenarios here where we also reduced transmission 20, 30, 40% during this time while these disruptions happened. We have further scenarios where we assumed that additional things might happen in the future in terms of COVID-19, and there might be an incomplete recovery of these disruptions. And then finally, we also looked at increasing the access to TB testing and diagnosis at certain level in a theoretical way to look at the recovery scenario. This is because we do not really have data for South Africa. There are measures implemented, but we do not have data on what these recovery measures yielded, unfortunately. This is just the no COVID base case scenario, obviously hypothetical, where you see the trends in notifications on the left-hand side, TB incidence and mortality over time, with a projected average annual decline until 2035 of 1.16% in South Africa. And we then looked at the total number of incident TB cases and deaths to calculate then later excess deaths attributable and excess cases attributable to COVID-19 and the pandemic. Just to briefly show, this is data for the pandemic scenario one. We have annual data here, and you see that the long-term effects of these disruptions are relatively mild for incidents. There's quite a substantial increase in people dying, so mortality here in the early phase while these disruptions happen, but we're projecting that the overall trend until 2035 will not be as strongly affected. This is assuming that, first of all, there's nothing else happening further with COVID-19, and also assuming that we see a complete recovery from 2022 onwards, which we are not fully sure yet. So that is a limitation, obviously. This is the number of excess cases and deaths happening during 2020 to 2022, and then also in the period from 23 onwards, so the current year up until 2035. And you see here a substantial increase in mortality, 6.2% compared to the no COVID scenario, with a slight increase also resulting from increased transmission in the following period from 2023. So this again is assuming that there is complete recovery after 2022, but still you have increased transmission because of the change in epidemiological trend beyond 2022. Very briefly, the pandemic scenario about reduced transmission, 20, 30, and 40%. I mean, this is probably a little high if you think about it. I am not aware of very good data that have looked at reduced contact or reduced transmission in South Africa, which we could leverage. But just to say is that our findings are very much dependent on what is assumed for contact reductions during this time. You see here that with a substantial decrease in contact through masks and through lockdowns, we would see a different pattern. We would even see a decrease in incidence and mortality over time, not initially for mortality, but eventually, but also relatively modest effects in the long run here. This is pandemic scenario 3, where we have some additional scenarios of long-term or long-term consequences of COVID-19. We see here there are additional people dying, additional people developing tuberculosis over time, with obviously the uncertainty that we don't know what is going to happen. So I'm going to keep this brief. And this is recovery measures, hypothetical 10, 20, 30% decrease in incidence in contact, and therefore transmission, obviously with the limitations that, this is increase in testing over time, 10, 20, and 30%. This is interesting in the context of universal testing and treatment in South Africa in primary healthcare facilities. But this is very hypothetical in terms of what could be achieved. But we assume from this that if measures are in place and if they are effective, we can not only mitigate, but we could also accelerate progress towards the end-TB strategy. Limitations, just very briefly at the end. I know that we are coming to an end of the hour. We want to leave some time for discussion and questions, but obviously we do not really distinguish between people accessing care versus people having access to TB testing, which is quite different and might be important. We have a lack of data for other relevant effects on along the TB care cascade, including initial loss to follow-up. Obviously, using aggregate data for the ARIMA model is problematic because it doesn't allow us to track the effect on an individual level and look at also delays as opposed to disruptions or as opposed to losses. We have also not the ability in this model to differentiate to what extent the catch-up that we've observed in the later time is owing to a true recovery because measures were implemented versus simply a backlog, for instance, of samples that were sitting around and not tested and then were tested with a delay. So these are all limitations. We have a lack of data and estimates for drug-resistant TB. And also we are not able with this analysis to capture more detailed effects. For instance, the profound effect of potential increase in susceptibility to TB due to worsening living conditions, which I think is extremely important to consider in South Africa. If you look at the city of Cape Town, where there have been surges of homeless people now camping and losing, first of all, lots of people losing their jobs during this time, having to camp because they lost the ability to pay for their accommodation. So you see a lot of homeless people in downtown Cape Town, undernutrition, people cannot afford food anymore. So this is really a profound impact which needs to be considered when we talk about potential effects of TB, and we didn't do this here. We also didn't have obviously a great account of interruptions of treatment during this time that could lead to a higher risk of relapse. And also we didn't consider catastrophic costs during this time and also other financial implications. So there are quite some limitations to what you can do out of this using the data we had. But we can conclude that there has been an excess burden during 2020 and 2022 of about 8,000 incident cases and almost the same number of additional deaths. A 6.2% increase, which is almost consistent with Finn and Richard's estimate of what could happen in terms of death in these countries in the absence of data, so in the early phase. We have seen that according to this analysis, we see an additional 21,000 incident cases and 4,000 deaths in the following time, so 2022 to 2035. This is assuming that South Africa is successful in recovery of healthcare services and that there will be no other COVID trouble happening down the line. And just to say that we do think that recovery measures are important, and we give some estimates of them being able to enhance progress if implemented well, and also accelerating declines in incidence and mortality towards the 2035 targets. Just at the end, I want to acknowledge a huge team that contributed, foremost I want to acknowledge Abigail de Villiers, who's on the call today, who has been working very closely with me and who's done a lot of the analysis that we presented. She's done really excellent work, and we're glad to work with her on diagnostics modeling now in Heidelberg together with Claudia Denkinger. And so she's been hugely behind this work. We had the other team in South Africa led by Anneke Hesseling, who was also the overall lead of the BRICS project, Mohamed Osman, Suan Mehan as well. The team Brazil, Annette Taiman, Claudio and others. The team India with Urvashi and others who contributed to this analysis. We have the SOSTIMA DGC TB modeling group, which contributed to the prototype of the TB model that we used, and who we will continue to involve. And we have the TB think tank assignment collaborators from NISTD, Hari and Farsana, the TB think tank task team, which I'm very happy to facilitate as a chair, which gave us input on the analysis. And then also thanks to Nim, who was not directly involved in this work, but who we're working with in a Gates-funded diagnostics modeling study at the moment, and who has supported the development of the model we used. The funders, obviously, the BRICS framework program, the South African M.Sc, and the South African TB think tank, to name a few. These are all the BRICS project partners shown here. But I want to close by that, and I want to thank you all for joining, and want to ask whether there are any questions or comments. Thank you very much.
Thank you, Florian. That was fabulous. And it was so nice to see the modelling that you're doing, really grounded in the data that you've been able to collect. It's very nice to see that in a modelling study. Okay, we've got about 4 minutes left, but certainly time for a question or two. I'm just going to take chair's prerogative and kind of combine Sandeep's question, which is in the chat, with one that I have myself, and then maybe give you a second. But those of you who've got a question as well, please put your hand up so I can come to you afterwards. So Sandeep asked, curious to know how you quantify the reduction of transmission during COVID. And I'd add to that, I found it quite interesting that in your, I suppose, base case is wrong, but kind of in a lot of your scenarios, you're not modeling any effect of transmission reduction. So I'm guessing that those numbers you get at the end don't assume no transmission reduction. And I know we don't have much evidence of transmission, no evidence of reduction, but it seems like a strong base case, a strong assumption to basically say that there was no effect, which seems to be those scenarios do agree. So I think it's Sandeep's asking about the kind of where do you get the number from, and I'm kind of saying, the fact that it's missing from many of your scenarios is quite interesting. And then my second point would be like, what's going on in India? I mean, it's really fascinating from the data that you suggest, going back to the data half, you're seeing almost the largest reductions in notifications in India, but it seemed to have no difference whatsoever on quality of care. Death rates were not higher. What is going on there? So there's a couple of questions to set you off.
Yeah, thanks. Trying to be brief to allow more questions, but essentially, yes. So reductions in transmission is a huge limitation to this work. We do not have very good data. I think there are some studies from KwaZulu-Natal that have quantified contact reductions, but I'm really cautious about contact and reductions in transmission, because where TB happens, especially in South Africa, I'm not quite sure whether the lockdowns really translated into reductions of transmission, because very often in communities and townships where people might have worn masks, but where it's very difficult, even during COVID-19, to shield yourself away, to stay in the house, because there are no houses essentially, but also the mask wearing was not very consistent, and there were huge people were dependent on going in buses still. And I'm so cut the long story short, I don't believe that there was a major reduction in transmission, but clearly if anybody has data on that for South Africa, I'd be really keen to hear. On your second question, what's going on in India? A brief answer, we don't know. The India team doesn't know either. We've been discussing that at length, and we are really trying to understand this better, but so far we don't know whether this is a lack of reporting, lacking quality of reporting, or whether this is true that they maybe did things differently. And it would be interesting, and also if anybody has has insights on that, would be really interesting to have those. Thank you. Thank you.
Melanie.
Hi, Florian. Fantastic talk. I'm just curious about sort of the increased death while on TB treatment. Obviously, some of those deaths are going to be coming from disruptions in TB care related to the pandemic. But I also imagine a number of those deaths would be directly from COVID-19 itself. And so I'm wondering if you've thought about ways to disentangle those two things.
Yeah, that's a very good point. We are not able, and I don't think that from programmatic data anybody can do this, but I fully agree with you that an increase in TB deaths is probably also related to death from COVID, but that is also something that other studies have to look into. We couldn't do that, but really interesting and important question, and thanks so much for joining.
Rowan.
Yeah, thanks also for the talk. We did the similar modeling in 5 countries, and I guess also saw this kind of some different results in countries. But for the potentially reduced transmission due to mask wearing and so on, a lot of the NTPs and our country partners were also equally concerned that overcrowding in urban residences during lockdowns might actually be increasing TB transmission during like stay-at-home orders. So that was, I think in the end we decided to leave it as we don't know anything. Yeah, could go the other way.
Good point. Thank you. Yeah, very, very good point. Yeah.
Now, unfortunately, that's a brilliant point, Rowan. Now, unfortunately, 1 minute passed, so I suspect we may need to call it a day, just because I'm sure people have back-to-back calls in their diaries. Florian, thank you very much indeed for the session. It was fascinating. I love the data. I love what you're doing with the model there. It's really exciting stuff. Can't wait to see it published. And thank you all for joining. And hopefully we'll have, if any of you have, lovely modeling pieces or pieces, work in progress, do get in touch with Finn. We would love to have you as a session on TBMAC so we can share the good work that you're doing. Take care.
Richard, just also from my side, thank you so much. Please get in touch if you have other questions or comments on this type of work. I'm very happy to discuss further. And also, if I don't know if we can keep the channel up, I'm happy to stay on for a few minutes for those who really wanted to ask questions. Other than that, please get in touch via email. So thank you so much.
Fabulous. I do have to drop off, but please stay if you can. Take care.
Thanks so much. So I'm going to stay in just for a moment in case there are any other questions. Please just raise hands. I'm going to monitor if anybody wants to ask or just speak. We're only 9 people left, so feel free if there's any other feedback if you have the time. Otherwise, have a great day.
This was really excellent. Thank you so much. I'm going to sign off now. Thank you.
Thanks, Anna. Good to see you.
Yeah, thanks again.
Yeah,
thanks.
Thank you. Also, don't have questions. I was wondering maybe just listen in if there are any else, but it was really interesting. Thank you.
Thanks, Lucas.
I don't think there's any more questions then. Thanks for it was well presented.
Yeah, so we should have maybe left a little more time, but I think glad that there were some quite interesting points made. Yeah, be nice to follow up with, especially with a person who said that there might be data on contacts. So can you just record the chat somehow that we have the comments in the chat? Be nice to keep those. Don't know how to do that. Yeah.
I'm not sure, but I can just screenshot them.
Yeah, I'll just try to export the chat. There is a way of doing that.
Yeah, okay, chat saved. Okay.
How did you do that?
There's like a smiley faces and like where there's all the different actions. There's 3 dots at the bottom of the chat.
Exactly.
Yeah.
Safe chat, exactly. Thanks. So I'll do that.
Yeah. Well, have a nice evening.
Have a nice evening. All the best. Bye.
Bye.